Good morning, everybody, and welcome to Pediatric Grand Rounds. Just a few announcements from me and some reminders before we get started. Please remember to stay muted during the presentation. When you have questions or comments at any time, you can put them into the chat box at the bottom of your screen. I will see them and share them with our speakers during the Q&A. You'll be getting an evaluation from our team by email in the next day or two, and please make sure to fill that out. It helps our speakers and it helps us plan future Grand Rounds. And our planners for Grand Rounds have no financial relationships to disclose. Also, I wanted to announce that we are going to be coming back live to Wright Auditorium on July 14th, so mark your calendars for that. We'll still keep the virtual option as we've always had, but if you feel comfortable coming back to Wright Auditorium, we'd love to see you in person. And now I will introduce our two wonderful speakers for today. First, Dr. Hannah Goldstein, who's an attending pediatric neurosurgeon here at Seattle Children's Hospital. She was born and raised in New York City, completed medical school at Columbia University, during which time she was the recipient of a Doris Duke Research Fellowship. Dr. Goldstein completed her 7-year neurological surgery residency at Columbia University prior to moving to Seattle, where she completed her Pediatric Neurosurgery Fellowship at Seattle Children's and then joined our faculty last year. And Dr. Samuel Browd, the director of Seattle Children's Hydrocephalus program, medical director of Seattle Children's Sports Concussion program, and the director of the Sports Institute at UW Medicine. Dr. Browd's innovations and collaborative efforts with UW Mechanical Engineering have led to a new force-reducing football helmet. Dr. Browd currently serves as an unaffiliated neurologic consultant to the NFL and an independent neurologic consultant to the Seattle Seahawks. We're so excited to have both of you here speaking at Grand Rounds, and welcome Dr. Goldstein and Dr. Browd. Take it away.
Thank you.
Great, thank you. Alrighty, good morning, and thank you for joining us. We're excited to be here. As mentioned, I'm Dr. Hannah Goldstein, and I'm here with Dr. and we're part of the Pediatric Neurosurgery group here at Seattle Children's Hospital. We wanted to give kind of an overview talk today, hit on the things that we deal with as pediatric neurosurgeons, and by association, the patients that many of you as pediatricians will see either before, during, or after their interaction with neurosurgery. The idea of today's talk is to encourage further dialogue and ultimately enhance patient care. Any one of the topics we're going to touch on today could easily be an hour-long talk within itself, and we're happy to come back and dive deeper if there's interest later on. Before we get started, we have no relevant disclosures. And we just want to introduce ourselves as well as the rest of our team. In addition to Dr. Browd, our partners include Drs. Richard Ellenbogen, Jason Hauptman, Amy Lee, and Jeffrey. So pediatric encompasses a lot of things. As pediatric neurosurgeons, we take care of all sorts of patients, from infants to teenagers, even into the with brain or spine problems. Again, we could delve deeper into these topics, but today we're going to highlight just a few. So this is the outline of the topics we're going to talk about, and we'll go into sort of pearls, pitfalls, and when to call a friend, aka your friendly neurosurgeon. Really, the idea here is to figure out who should or who could be a neurosurgical patient.
Okay, so I get to start off with our favorite thing, which is hydrocephalus. So hydrocephalus in a typical pediatric neurosurgery practice probably accounts for maybe 50% of what we do. In our practice, it's a bit less than that, but hydrocephalus is a very common thing. So we'll go through what to look for, because you will certainly have patients in your practice who have hydrocephalus, and while we, work very hard to educate the families, we want to make sure that it's very clear when there are issues and when they're not. And any time that there is a question, we want to hear from you guys if you're worth something. So hydrocephalus, folks will refer to this as water on the brain. It's an abnormal collection of spinal fluid. So you're either not reabsorbing that fluid properly, being overproduced by some mechanism. Um, Ventriculomegaly is typically seen on imaging studies, as you see in this picture here. Size is significantly enlarged. That can cause compression of the brain. Not everybody who has ventriculomegaly has hydrocephalus, and so that's a common thing that we're assessing in kids who might have brain atrophy, for example, for some reason, and have big, but they may not have increased pressure. So how do you get hydrocephalus, and why does that happen? So it can be a blockage of flow. So you can have aqueductal stenosis, for example, that leads to this. As a production of CSF, you can see that in different tumors like cord plexus, for example. Or more commonly, it's caused by inadequate spinal fluid. We don't know totally why this happens. There are many hypotheses out there, and not every kid is black and white, that they either don't absorb or they absorb to a degree. So it's actually fairly complicated thing within neurosurgery, assessing these kids and determining who needs a shunt. Next slide, please, Hannah. This is, the most common thing we operate on in pediatric neurosurgery. It's when kids get brain surgeries to deal with hydrocephalus. So it's quite common. There's over 30,000 shunts placed in the US alone annually, and about 10,000 revisions that are done. Again, we see similar kind of proportion within our practice here. The incidence is about 0.7 per 1,000 live births. And not all the kids who have ventriculomegaly at the time of birth go need shunting, but they're commonly folks that we're going to follow through our clinic for macrocephaly and make a determination whether or not we're concerned about pressure, which would then lead to a shunt or some other type of CS diversion procedure. There are a lot of people with shunts out there. I think this number is probably underestimated, honestly, 125,000. But it's quite common. Certain every pediatrician on this call has kids with hydrocephalus in their practice. Next slide, please. So the etiology of this, it's extremely common. And for that is it crosses a myriad of different etiologies. So interventricular premature infants, common reason that we're getting involved. About 80% of kids with myelomeningocele end up being shunted, and those numbers have not changed appreciably over the years. Quite common after resection for brain tumor to need a shunt. Aqueductal stenosis, as we discussed. In the setting of meningitis, kids often go on to require shunting. Head injury, moderate, and certainly in severe head injury, it's quite common to need a shunt after those injuries. And there's a variety of other etiologies that come in that end up needing treatment. So let's just review signs and symptoms. So these are signs and symptoms generally of increased intracranial pressure, but as I mentioned before, hydrocephalus is actually quite complicated. I talk about it as shades of gray, and some symptoms may be present that may not be present, but if you see them in your kids, whether they're shunted or not shunted, it should raise some level of concern. So in shunted kids, we'll see irritability if they have high pressure, nausea, vomiting, obviously headaches, common feature. Lethargy can be a downstream component. Rarely, but on occasion, we'll see seizures as part of this, diplopia, and certainly school performance, as you can imagine. So physical findings, increase in the child's OFE, critical component for us when we're assessing the kids to look at head circumference. Now, delayed development, upgaze, palsy, again, decreased level of edema. 6 nerve palsy, we actually see that not uncommonly in kids who present with, and then other findings here. Next slide. So when we see these kids coming through, whether it's a new evaluation or a child who has a shunt, we're going process. We're going to do just standard physical exam, go through those signs and symptoms that we mentioned. Really, for a lot of the kids who may be delayed, for example, it's really important to know what their neurologic baseline is because we're often comparing against that. And so some of those signs and symptoms are harder to determine in kids who have hydrocephalus. And then imaging is a mainstay for us to look at what's going on with these kids. So we historically have done quite a number of CTs, and we've tried to get away from that in the last number of years where we're doing rapid sequence MRIs to reduce the radiation. So we're able to do that, we default to do the MRI to garner this information about ventricular. And this all leads up to the surgical evaluation, whether we think there's signs, symptoms, indications on thing that drives us toward thinking either the child needs a shunt or needs a revision if they have a shunt with symptoms. Ophthalmologic evaluation is also part of this workup on occasion to look at them. Next slide. So treatment options. If the child's coming in very sick, or for example, we're immediately after surgery, we'll place a EVD catheter. So this is a single catheter that goes into the ventricle, drains externally. So we can manage that for pressure, flow, and understand and try and see child needs a permanent system. In little babies that are typically under 2 kilograms, IVH and hydrocephalus, and we'll place a subgaleal reservoir or shunt. That's a measure typically, and then they need to get shunted later. You probably heard a lot about endoscopic third ventriculostomy. About 8 years ago or so, we thought this might be the end-all be-all for hydrocephalus and allow us to avoid typical shunts. There have been innumerable studies. About 25% of patients may be suitable candidates for ETV. So we always see if we can avoid a shunt. ETV is done with an endoscope. It creates a diversionary channel to move out of the ventricles. And the idea there is to avoid a permanent implanted shunt. Shunts can be placed in different locations. So essentially what a shunt is doing is you're draining spinal fluid from the to another place in the body where it can be reabsorbed. So our typical go-to spot is into the peritoneal cavity, but we can also place them in the pleura. We can place them in the atrium. Some kind of historical other places that we don't use anymore are bladder, and you can even put them intraosseous, but uncommon now. And then there's also things called lumboperitoneal shunts that we use in circumstances. Next slide, please. So the shunts tend to contain 3 components. There's a catheter, we call the ventricular catheter. That's the one going into the lateral ventricle most commonly. It's connected to a valve. These are what are called differential pressure valves. So they basically control how much fluid comes out. Newer valves are called programmable. Better term is adjustable. They're not smart shunts, so we can basically external magnetic device go between different pressure settings. So some kids need a lower pressure, some kids need higher pressures. And so we'll spend our time, after the surgery, adjusting and determining what's the right setting for that kid. And then there's tubing that goes down to the terminal location, whether that's the peritoneal cavity or pleura, and that's called the distal tubing components. At a revision operation, we're checking all 3 of these to see which component's working or not, and then we replace whatever's failed. Next slide. Again, symptoms of shunt malfunction similar to increased intracranial pressure, nausea, vomiting, headache, lethargy, seizures, diplopia. School issues are hard. That can be a symptom on occasion. And then same sign. OFC in a child whose fontanelle is open, delayed development, gaze palsies, and the other findings seen here. So the takeaway from hydrocephalus is it's actually quite complicated. If there's ever a question, we're always happy to talk to you. We try and empower the parents. They know their kids better than anybody. And if they're worried about their child, we have an amazing group of nurse practitioners, and we have our clinic and want to see these kids if there's any concern. But any real significant findings of intracranial pressure is a direct trip to the emergency room for us to figure that out. And we're always happy to talk to you if you have questions. I'll pass Yeah.
Great, thank you. So we'll move on to our next topic in our whirlwind tour. So concerning lumps, bumps, and dimples. They come in many flavors and varieties. Some of them truly indicative of underlying pathology, others simply sacral dimples or birthmarks. And hopefully, next few slides will kind of tease out a little bit better of an idea of which kids need to be worked up further and why. So what are we concerned about with these cutaneous back findings? What we're looking at is their spina bifida, and that can be an open defect or a closed defect. And this defect, spinal dysplasia, occurs early on during embryogenesis, really during the first post-conception. And it's a defect in neural tube closure, and there's a whole range of pathologies. So open neural tube defects, or myelomeningocele, which you can see in the top right here, are pretty obvious. These are generally diagnosed prenatally, assuming that the mom has good prenatal care. They are not diagnosed prenatally. But what can be more subtle and much more difficult to diagnose before the child is born are some of the closed neural tube defects. And these include things like dermal sinus tracts, lipomyelomeningocele, myelocystoceles, fatty phylums. Some of them do have obvious cutaneous, a lipoma on the back, or some of the pictures that we'll get to in a minute, and other ones have little to no outward signs of spinal dysraphism. So I think anyone on this call today would know to be concerned about one of these, right? These are pretty obvious pictures. You're worried, is this indicative of a midline defect? Where there's more uncertainty, again, are with some of the more subtle dimples or hemangiomas that may or may not represent something deeper. So a good rule of thumb is if there's a dimple that you're worried about, but it's located within the gluteal folds, within about 2 to 3 centimeters of the anus, even if you can't appreciate visually the bottom of the tract, if you can feel it kind of where the coccyx is, it will terminate either more superficially or at the tip of the coccyx, which is below the level of the spinal canal. So typically speaking, these are not related to neural tube defects. That being said, similarly, if there is any concern, we're sort of happy to evaluate these patients. And we actually have a babies conference where pictures can be sent, and one of our neurosurgeons, as well as one of the neurodevelopment docs, help to determine if further workup is warranted. And what does that workup entail? So for newborn children, or really under about 3 months of age, we can actually get a spinal ultrasound. It's quick, it's painless, there's no radiation, but unfortunately it can only be done until about 3 months of age because the spinous processes are still cartilaginous enough that you can see through them with an ultrasound. If the child is older, or if there are concerning findings on the ultrasound, then typically we will recommend an MRI to better characterize what's going on. This gives a very detailed image. There's still no radiation. However, it does typically require sedation for children above about 3 years of age. And if a child is found to have some sort of dysraphism, then we typically recommend surgical intervention. And that's really often done prophylactically. So we want to prevent neurologic, urologic, and orthopedic delay. So we know that for open neural tube defects, one of the biggest concerns is infection, right? And so if something's open to the outside world, it means bugs can get in. And so we recommend basically immediate intervention. A child born with a lipomyelomeningocele does not leave the hospital before it's fixed, and typically we fix it within about 24 to 48 hours after birth. For those neural tube defects, on the other hand, what we want to prevent is stretching of the spinal cord. apologize. I'm getting a message about switching my share. There we go. Hopefully that is better. And this nerve roots and the spinal cord really happens as the child grows. And so we typically elect to do these repairs closer to about a year of age. And we wait until the child is a little bit older for a number of reasons. Number one is anesthesia. It's just a little bit easier, a little bit safer when the child's older. The other is that the tissue layers are a little bit more robust, allowing for a better closure. But in general, it's a discussion that we have with the patient's families after we have appropriate information about what needs to be done and when is the optimal timing. So then rounding out diagnoses that are seen within our infant population before we get to kind of the child pediatric range is craniosynostosis. And that's the premature fusion of one or more of the cranial sutures. Importantly, craniosynostosis is not the same thing as plagiocephalus, an asymmetric skull, but does not involve sutural closure. The fused suture impedes overall skull growth, and because of that, it impedes kind of the room that the brain has. And so this can actually lead to ICPs in up to 15% of children with just a single suture that is fused. And so that's really the reason that we recommend surgical intervention. And again, before that child has issues related to increased ICPs. So what one can see here, I've just pulled up the standard circumference curves that I'm sure you're all very familiar with. And we know that the brain, and thereby the skull, is growing very rapidly, really during the first 2 years of life. So you get about 75% of full brain volume growth during the first 2 years. And anything that impedes that growth can have deleterious effects on brain development and overall outcomes. So craniosynostosis is relatively common. We see a lot of it here as we're kind of one of the main centers for craniosynostosis, but it affects about 10 to 16 out of 10,000 children in the US, most of whom have non-syndromic craniosynostosis. There's no family history. Familial do account for about 5% of those, and sagittal synostosis is by far the most common. So the mainstay of craniosynostosis is based on the physical exam, looking at a child's head shape. And this is often first noticed by the pediatrician, more often than the parents, even as they're sort of used to seeing their kid and their kid is their normal. Skull growth is impeded in a certain direction because of the fused suture. You get compensatory growth in the perpendicular direction. And I'm going to go through briefly kind of the characteristic head shapes associated with each form of craniosynostosis. That being said, skull x-rays can be helpful in craniosynostosis as they'll show the fused suture. And we do get CT scans, which are helpful not just in diagnosis, but ultimately are important in preoperative planning. So again, any child that you are worried about, we have a craniofacial center here that does treat kids both with craniosynostosis and with positional plagiocephalus. And our craniofacial medicine doctors are great at sort of teasing out what is what and what the best management is. So I'm going to, again, just go through kind of briefly head shape. So when you have sagittal synostosis, you have lateral skull growth restriction. So you get compensatory AP elongation and this characteristic scaphocephaly or elongated head shape. With coronal synostosis, it's sort of the opposite. You have AP skull growth restriction, and so you get compensatory lateral and craniocaudal elongation and the shortened or brachycephaly head shape. Coronal synostosis can be unilateral. In unilateral cases, you have pretty obvious orbital asymmetry, and this results in what's known as the harlequin eye deformity or a raised eyebrow. This also has some skull base implications. And then with me have lateral growth restriction just anteriorly. So you have a triangular forehead, essentially, with ridging, closer set eyes, and a narrow biterional distance. And then finally, lambdoid synostosis, you have ipsilateral occipital flattening and mastoid bossing, and a sort of flattened posterior skull. So I want to spend a little bit of time talking about deformational posterior plagiocephaly versus this, because these are often confused. Positional plagiocephaly is common and doesn't require neurosurgical intervention. So there are key ways to recognize the difference, but again, if you are ever concerned, our craniofacial center here is great at assessing children and figuring out either just based on head shape signs or further imaging what is what. Lambdoid synostosis, with the ipsilateral occipital flattening, you have contralateral frontoparietal bossing and posterior displacement of the ipsilateral ear. Whereas with positional plagiocephaly, you have ipsilateral frontal bossing and anterior displacement of the ipsilateral ear. And so what's important is that with posterior plagiocephaly, again, it's really just a head shape issue, and you wind up with more of a parallelogram head shape. Whereas with true synostosis, it's an issue of growth restriction and results in more of a trapezoid head shape. And because everything is sort of pulled back, it's not allowed to push forward. So again, positional plagiocephaly, by far and away more common, does not require surgical repair, in fact, would not benefit from surgical repair. However, lambdoid synostosis needs surgical intervention. So that gets us to our, assuming you do have true craniosynostosis, they're just with helminthine alone. And there's sort of two mainstays of surgical intervention: open surgical correction and endoscopic assisted suturectomy. With open correction, you have a full remodel of the skull. It's typically done in kids at least about 9 months old. It's a larger surgery, longer operative times, higher blood loss, rates of blood transfusion, slightly longer hospitalizations. But once it kind of heals from their surgery, you have immediate head shape correction. Endoscopic suturectomy, on the other hand, involves just cutting out the fused suture, and you're relying on the growing brain to really reshape the skull and the head with some assistance from helminthine therapy. And so because it relies on the rapid growth to do that reshaping, it's done in younger patients, typically about 3 or 4 months of age, but it is a shorter surgery, lower rates of blood loss, lower rates of transfusion. Sometimes hospital stays are just a single night, but then afterwards, most children are in a helmet for up to about a year. So the answer in terms of which treatment to pick, again, it's a discussion that we have with each individual patient's family to figure out what makes most sense for their child and their presentation. And then I'm not going to actually go into these for the interest of time, but I did want to mention that there are described clinical syndromes associated with craniosynostosis. I've listed the common ones here. They're often associated with some limb deformities, mid-face deformities as well. The key thing is most of them involve multiple suture craniosynostosis, which can lead to very elevated ICPs early on, and so they need to be early and sometimes actually in staged procedures. Hand it back over to Dr. Browd for our next topic.
All right, thanks, Anne. I'm going to go through Chiari malformation. This is another thing that I'm certain everybody on the has seen in their practice. So the way we talk to parents about Chiari is they have a size 10 brain and a size 8 skull. So what they end up having is crowding and the cerebellar tonsil. So the definition of Chiari on imaging is cerebellar tonsillar placement below the foramen magnum of 5 millimeters or more. And there's many different types of Chiari malformations, but the two most common that you'll see are type 1, thick, and type 2 is associated with myelomeningocele. And of Chiari that are variations on the theme, or they can be seen as Hannah indicated syndromic conditions. The epidemiology of this is somewhere between 3 to 3.5% of the population. So it's not an uncommon thing that you'll see in your practice. Every week, Hannah and I are seeing different people coming through who have Chiaris that were. Dr. Ellen Bogan is the main person within our group who's been doing this for years. It's often seen as an incidental finding, and so see this is typically a good case to refer over so that we can evaluate and see if there are other signs or symptoms. Next slide, please. So signs and symptoms of Chiari can be really quite distributed, actually, and what I tend to look for just straight off are really headaches. These can be occipital or frontal in nature. They're often brought about by Valsalva type maneuvers where they're bearing down or they're at play, jumping up and down. So you can have these occipital, cervical, or tussive headaches. Sometimes they can have back pain or shoulder or limb pain, and that can be because of a syrinx that develops in the spinal cord. We'll talk about that. Again, clumsiness. If it is involving the brainstem at all, it's important nerve exam when you see this because you can sometimes see dysphagia or dysarthria. Common, but it's definitely, if you see that, an indication that they need to be seen right away. Nystagmus, as I mentioned, lower cranial nerve palsies. The syrinx can be a common finding in kids with Chiari, and so it's often picked up in scoliosis evaluations. So one of the things that is complex spine in our practice, and often the orthopedic surgeons are referring scoliosis because they've done an MRI and they find that they have a Chiari or syrinx present. Hoarseness, hiccups, rarely urinary incontinence, and then paresthesias. So things though with tussive sort of features to it are the most common thing that we tend to see. Next slide, please. So we're going to go through and do a very detailed physical exam when we see these kids. This includes, as I mentioned, the cranial nerve examination. We want to look and really examine their extremities, understand if reflexes. Standard of care in this setting is an MRI without contrast, both of the brain and the spine. On the brain, we're looking again at the size of cerebellum and the descent of the cerebellar tonsils. We can see this range anywhere from the minimum cutoff all the way to 2 centimeters going down the cervical canal. So there can be some quite pronounced findings. And then we're really looking also at the spinal cord to see if there's a syrinx. This would drive surgical decision making for certain in most cases, and so it's an important piece of the evaluation. Next slide. So the treatment for Chiari, who and when, depends, right? So these are going to be decisions based on a variety of things. What are the signs and symptoms? How long have they been going on? What does the imaging look like? Do they have a very minimal 5 millimeter Chiari and it was incidentally picked up? We may watch those kids and serially image them every year, every other year. If they have a spinal cord syrinx, that's generally going to drive us to a decision with decompression. And so the way we treat these, there's really two general approaches. One is to do a standard decompression where we do a suboccipital craniectomy. We take some of the bone off. We open the dura, place a patch, create more room there. And then typically we're going to shrink the cerebellar tonsils with cautery during the surgery. That's pretty typical way of treating Chiaris. There are other ways that we'll do this depending upon the patient in the scenario, where we may just do a bone only opening and leave the dura intact. And so some of that is assessing at the time of surgery with ultrasound, whether we've created enough room and reestablished normal CSF flow around this cerebellum. Take into account if they do have a syrinx, and generally in that case, they're going to have an open call it. So fairly complicated. We'll watch these kids closely if we're monitoring, and certainly after surgery, we'll want to see resolution, or at least the size of the syrinx as a sign of success for the operation, as well as amelioration of symptoms. It's a super effective surgery for that. Next slide, please. And symptom improvement, improved headaches, cranial neuropathies, looking in those, CSF outflow, and reduction in size of syrinx. We see a picture here showing a pretty large syrinx on the left. And after Chiari decompression, you can see the cerebellar tonsils are no longer hanging down as low as they were before, and the syrinx has become much smaller. So these are the things that we're looking for in the postoperative period. There's obviously some significant complexity around Chiari, some kids like that, but that's part of the evaluation as we go through. So I'm going to go through briefly spasticity and cerebral palsy tone management. Dr. Miz has been kind enough to invite me back to give a grand rounds later this year on this and to go deep on this, but we're going to kind of cover it at a high level, and then I'll come back and give everybody a bit more later this year. So kids who have cerebral palsy in their practice, and one of the things that I'm on my soapbox about is that I want these rated early for spasticity and dystonia, because there's often interventions that we can do that will how the kids can ambulate and also just ease a lot of their care, especially kids who are significantly involved. So CP can spasticity and dystonia. Largely, the surgical treatments are geared towards implants, which we'll talk about, like a baclofen pump, can treat both entities there. So spasticity, we say you can dystonia, you can see. So spasticity is the catch. You kind of move somebody's extremity, and then this is a velocity dependent reflex mediated at the level. Dystonia is involuntary movements with muscles co-contracting, and it can be worse with voluntary movement. That's derived in the brain. It's not a spinal cord issue. So these are very different things that we're evaluating the kids who come through rehabilitation in our joint clinic here. Next slide. So when we talk to the families and in your practice, we're looking at the geometric motor function classification scale. This is looking at how independently the kids can get around. So it ranges from level 1 all the way up to level 5. Level 1 able to ambulate and do most things on their own. Level 5 severely affected by what's going on, wheelchair dependent. And so we have different therapies, both surgically and baclofen pump, to treat all of these kids in different ways. And so it's important to so we can make an assessment. Next slide, please. So at Seattle Children's, over the last decade, my colleagues here, we built out a multidisciplinary program to evaluate the kids. So this includes not just neurosurgery, but our PM&R rehabilitation colleagues, as well as orthopedic surgery. These kids, as everybody on the call knows, are quite complicated and are on different medications. And one of the goals of surgical intervention is to reduce the need for some of the medication, just improve their overall level of care and function. So when they come in, we're going to do a very extensive, sometimes multi-day evaluation of these kids. Next slide. So again, we're going to focus on, certainly the history, surgery in this patient population, of what are the goals of the family. So spend a lot of time talking to them. Is it to make Do they have pain? Is it a challenge taking care of them, perineal care, other things like can influence or impact by doing surgery? Musculoskeletal, a lot of the kids will require orthopedic surgery, and there's often a timing issue of do you treat the doing orthopedic surgeries. It's well known if they continue to have high tone that the need for repeated orthopedic procedures is quite high. So a mainstay of care for these kids is tone management. And obviously their neurologic exam. We partnered with our physical therapists and occupational therapists, and these kids get one of the most intense evaluations this program. And again, it's quite multidisciplinary. And when we do this clinic, relay the findings of the group to them. Next slide, please. Certainly non-surgical management, and that happens quite commonly, certainly out in the community and through physical therapy, bracing, oral medications such as baclofen. Injections are part of the main, I would say, a less common feature, and then certainly orthopedic surgery as well, although that is surgical management. So neurosurgery really tends to fall into a couple camps. So we are implanting intrathecal baclofen pumps. They're often in the kids who are GMFCS 5 or have a high level of typically will drive that decision. We have been one of the leading centers for universal rhizotomy around the country, and I would encourage everybody on this call and to tell your colleagues that if you have a child with CP with spastic diplegia, please send them to us. We want to see these kids when they're young. The sweet spot for surgery is somewhere between typically 4 to 5 to about 8 years old, but we've operated on kids, and the adult colleagues do this in adults. So there's not a time limit to be able to do it, but it's better to you reduce the need potentially for future orthopedic procedures. So kids, we've also pioneered using interventricular baclofen, and those are large. There's a predominance of dystonia. We'll actually put the catheter in the brain ventricle, and you have GMFCS level 5. These are the basically significantly impaired kids. We're now offering what's called selective ventral, and we call this for comfort and care. These are kids who are never going to ambulate independently, who are significantly impaired, and we can, instead of placing a baclofen pump, do a rhizotomy procedure to reduce and significantly lower the tone in their legs and pain for those kids. Next slide, please. Baclofen pumps, very quickly. This is a technology that's been around for better part of 20 years. There's a catheter that we place into the thecal sac. Catheter, either lumbar, cervical, wherever we'd like to place it. It connects to a pump and gives a dose of baclofen continuously to these patients. They can be titrated or just the pumps usually last about 6 years, need to be replaced at that point, and they're refilled typically percutaneously every 3 to 5 months, depending upon how much medication is used. It's quite effective therapy at lower, baclofen. It's non-sedating. Most of the kids come off oral baclofen. It treats dystonia and spasticity, and we can get effect depending upon where we put the across the full body, legs, arms, trunks, face, etc. Again, this clearly improves spasticity. It helps with gait, and it also is quite commonly used in the kids who are GMFCS 4s and 5s, and we see significant improvement in that bring them to surgery. Next slide, please. The rhizotomy, much more when I come back, but briefly, this is now done through a very small incision, about a centimeter. Open up, we expose the nerve roots, we test, and the reason it's select quite different. So we test the nerves, the ones that respond abnormally, certain percentage of dorsal or sensory nerves are cut, all the motor nerves are preserved. So that It's about 3 hours. The kids then go on to extensive rehabilitation, both for a period and as an outpatient. But this has been shown to be a very exceptional result. Next slide, please. With both reduction of tone, it's quite low risk operation. And again, what we see with these kids that the need for orthopedic surgeries can be reduced. My favorite operation. Great, and the families are extremely happy with this operation. It's life-changing. Again, we're typically treating or 1, 2s, and 3s with this, but also have been doing ventral dorsal or 4 and 5. So happy to see any kids in your practice who you think this could be a consideration for. We want to make sure that folks in the community are referring these kids because we know many, many more out there that are not coming for evaluation. Next slide, please. As an example, real briefly, this is pre-op, post-op. So this child came in, you can see tiptoes, walking a significant tone, scissor gait. This is probably a surgery. He's using a cane walker. His gait mechanics are significantly improved. And I can go on for an hour, which I will do later this year, and explain why it's life-changing for these kids. So for the sake of time, I'm going to pass it on to Hannah.
Great, thank you. So we've got a couple more topics to get through. We're happy to come back and dive deeper. I'm going to touch on one of the main things that I do here. And again, it's part of this just figuring out who should be referred for surgical workup. Epilepsy or recurrent unprovoked seizures. So this doesn't include things like febrile seizures, seizures. But of note, after a single unprovoked seizure, the risk for another is percent. And medically refractory epilepsy, which are those kids we're looking at, will surgery help, refers to seizures that persist despite adequate trials of only 2 appropriately chosen anti-epileptic drugs. Most children that we're seeing in our practice here failed 4, 5, 6, 7 different anti-epileptic drugs. And really, we know that after failing 2 drugs, the chances of seizure freedom with further treatments is diminishingly small. So about a third of patients with epilepsy do have refractory epilepsy, and those are the kids that we really want to evaluate to see if they're surgical candidates. So epilepsy can be caused by a myriad of different etiologies. Some of them have imaging, cortical dysplasia, underlying tumors, remote trauma, a number of different neurocutaneous syndromes. I'm not going to go into all the causes here. But regardless of the cause, patient, again, with medically refractory epilepsy should be referred for surgical evaluation. And this is another one groups where it's really an interdisciplinary process. It's a group of us consisting of neurosurgeons, epileptologists, neuroradiologists, geneticists, neuropsychologists, and patients undergo a pretty extensive non-invasive workup first, consisting of various imaging modalities, EEG, neuro testing. There may be surgical workup to better seizures, and this can be in the form of minimally invasive stereo EEG electrodes, so truly just sort of little wires placed into precise locations with to try to pick up seizure activity, figure out where the seizures precisely are starting from. This is more accurate than just the scalp electrodes. Or it can be the additional placement of a subdural grid. That's a bigger surgery where we want to also map brain function. So in cases where the seizure onset zone can be localized, meaning that we can pinpoint one area of the brain where it seems to be starting from, we offer resective surgery. And resection can be done, again, with minimally invasive tools such as laser ablation, or sometimes it involves much larger open resections involving taking out an underlying area of abnormality or even an entire lobe. Sometimes an hemisphere is implicated, in which case we can disconnect the bad side of the brain from the good. And that's, sort of one of the biggest surgeries that we do, and yet I have yet to meet a family that after doing it is not so grateful. And usually the question is, why didn't we do that sooner, right? The gains that children make are pretty incredible. In cases where there are multiple seizure foci, or occasionally when the focus is in an area of the brain where we feel that removing it would cause unacceptable morbidity, we offer things like neuromodulation. So it doesn't mean that they're out of options, but we can still overall decrease seizure burden, sometimes 75 to 90% reduction. And this was traditionally done in the form of a vagus nerve stimulation, but it's increasingly to include things like deep brain stimulation and responsive neurostimulation, which can either target specific areas of the brain or kind of with more generalized neuromodulation, we target the deep thalamic nuclei. So again, regardless of etiology, early surgical intervention is key, and that's for a number of reasons. We know that seizures are bad for the brain. So intractable seizures during the first 24 months of life are a significant factor for mental retardation. Inadequately controlled seizures can result in impairments in cognition, language, social skills, communication. And not to mention that children with uncontrolled refractory epilepsy are at higher rates of morbidity, right? We know that the overall mortality risk is 0.5% per year, and that accumulates over a patient's lifetime. So while a third of patients do have medically refractory epilepsy, a majority of these patients actually have surgically curable epilepsy. Up to about 65 to 80% of children with medically refractory epilepsy can become seizure-free after appropriate surgical intervention, and that's huge. Surgery can then, even if we don't get rid of seizures 100%, can lead to huge improvements in terms of development, behavior, attention, IQ scores. We see improved school performance, adaptation, and really improvements in overall quality of life, both for the patient and their family. So I'm going to sort of breeze through our last topic in the interest of time, which I'm going to briefly touch on brain tumor. We could come back and do a much bigger talk on any of these, but I would say is, as neurosurgeons, we are often the first ones to tell a family that their child has a brain tumor. And what I always tell families is that while that's hopefully a one experience for them, it is something that we deal with all the time. I would say, within our, probably on a weekly basis. Brain tumors are the second most common type of tumor in children, leukemia, lymphoma, and they come in all sorts of flavors and varieties. Some are benign, many are curable with surgery alone. Tumors can present with any host of symptoms. Large before being diagnosed, they'll often present with symptoms of increased intracranial, either the mass or obstructive hydrocephalus. They can present with focal neurologic findings, or they can present with seizures. And the key thing here really is that any child with a suspected brain tumor needs imaging and needs a neurosurgical evaluation. So in children who are very symptomatic, that's a quick non-contrast head CT to start. Sometimes we need to intervene before we can get a longer MRI study, and a full, generally do image the brain and the spine. Exact treatment, again, is very variable. We don't have time to go into all the nuances of the types of tumors and the types of surgery that we do. But surgical intervention, again, ranges from open surgical resection for cure, stereotactic needle biopsies, certain types of tumors, sort of minimally invasively with laser ablation. And the key thing here is, again, it's a team approach. And I think we keep coming back to that idea. So for our brain tumor patients, it involves not only the neurosurgeons, but also the neuro-oncologists, the pathologists, the radiologists, and sometimes other folks as well. And I want to sort of put this in, it often starts with all of you guys, right? The pediatricians. You see the patient, one of us, I'm concerned about this kid. There's this abnormal presentation, or when you're, just sending the kid to the ED, and starting that initial evaluation is key. So I know that was a whirlwind. Most things pediatric neurosurgery, and there are still many things that we didn't touch on today. Hopefully, at least an overview of what we do as pediatric neurosurgeons, clarity with what neurosurgery patients do or can look like. And we're happy to take any questions. We want to thank you all again for having.
Follow us on Twitter. We'll post some cool stuff on occasion. Fun for everybody to see.
We definitely will. Thank you so much, both. We will definitely have you back for further topics, and we already have one on the book, so thank you for that. We have 5 minutes for questions, which is great. And there was a question way back in the chat from Dr. Trehan about one of your first topics. Why do so few children you see qualify for ETV CPC? In the famous New England Journal trial from Uganda, I believe only a third didn't qualify. Most of these patients were post-meningitis as opposed to congenital anomalies. So maybe that's why.
Yeah, I can read. We were all incredibly excited. That's work from Ben Worf, who's a close colleague of ours. It's a completely different patient population, and we did multi-center trials here. We kind of led some of those through Seattle Children's, and we found that the they've had in Uganda were not represented in practice in the United States. So we were doing this on everybody at one point as a first line. We backed away because there were many kids who failed that therapy, and so we're much more selective now. There's certainly a group of weight shunts, but it unfortunately wasn't the kind of cure that we were all hoping for hydrocephalus. But we evaluate all the kids and look and see for that. But unfortunately, kind of it's become clear that a relative direction for that procedure.
Thank you. And then Dr. Marshall from Pulmonology. Thank you for this great presentation. Interested in hearing more associated with Chiari malformation. Is the cough neurogenic and prominent and something we should think about as pulmonologists seeing kids presenting with cough? Or is headache really the prominent presentation precipitated or associated with cough?
So it's definitely headache. So what you're doing, what we think is happening, you're valsalving, and so you're actually, when you're coughing, you're increasing the pressure in the, and that probably jams the brain down a little bit, and then they get a headache or they feel. So it's not a primary pulmonary thing. It's a result of coughing that increases the pressure within the, and that leads to the symptoms. At least that's what we think goes on.
Thank you. I'll wait a couple of minutes for questions, but in the meantime, Dr. Browd, can you just give us a little bit of a teaser about what your next grant will be about? If you know.
Yeah, no, happy to. So, excited to deep on, surgical treatment options in cerebral palsy, especially we're going to talk specifically around tone management. We've been, trying to lead around the country, getting, access to pumps and that type of therapy, but educatively around how some of these technologies can be used. I mentioned dystonia, placing the catheters in the brain, but we're going to really talk quite a lot around selective dorsal rhizotomy procedure, because I think there's some misconceptions, and a lot of kids, as I mentioned, are way to us quite late, and we'd like to make sure that everybody has good familiarity with the surgery. That may sound scary, and so we're going to go into some depth around what we do and certainly the outcomes, which are spectacular. It's so fun to do those cases and sending us pictures and videos and all that good stuff. So I'd be excited to spend an hour with you guys talking about it. It is absolutely my favorite operation to do.
Outstanding. And I believe that is in Grand Rounds, and you will get to see Dr. Browd again. All right, perfect. Then so thank you so much, Dr. Goldstein and Dr. Browd, for sharing your knowledge with us from you in the future. And we will see you all of our viewers with us during WebEx times, and we'll see you all next week. Have a great Thursday. Thanks, everybody.